Hi folks, this is Dr. Rob Cywus. I am the Carb Addiction Doc, and this will be the final chapter in a series of videos we've done on statins, on lipids, and really understanding it. Now, I've taken a deep dive. I know it may have confused a few of you, but this video is really going to look at when should I take a statin, what's a reasonable indication, and what should my blood work be, what blood work should I be looking at. So the first thing, I get a lot of requests for people, oh, I need to do an NMR. I want to know what my lipid fractions are. I want to know what my ApoB and my APO100 and my particle number. Folks, those studies are 100%, in my opinion, useless. You're pissing away your money. If you want it done, I'm happy to order it. I'm happy to analyze it. But I don't need those numbers to tell you what your cardiovascular status is. The lipidologists, the cardiac people, oh, you got to get this, because they're desperately looking for a fraction, for some number to correlate with cardiovascular disease to convince you that you should be on a statin. The problem is lipids don't cause that damage. But there are some very, very important simple numbers that can be seen in any basic screen of lipids that absolutely directly reflects your level of insulin resistance, your genetics, and how your body is coping with the chronic excessive carbohydrate consumption that you've done as part of a standard Western or American diet. So please understand that there is no cardiovascular risk from eating fat. In fact, there's cardiovascular benefit from being in ketosis. That's the number one thing. All the lipids do not cause damage. They are markers of damage. So if there's a hole in the if there's a hole in the road and there's a red flashing light, that's what the lipids are. They're the red flashing light. They are not the hole in the road. The hole in the road is cardiovascular disease, and there are certain lipid markers that are a marker of a hole in the road. But if you use a drug or if you use an intervention to get rid of the flashing red light, the hole in the road is still there. And that is why statins, for example, do not correlate, for the most part, by lowering LDL with an improvement in cardiovascular risk, absolute cardiovascular risk. They do not. Lowering LDL does not correlate with a reduction in cardiovascular risk. And even the anti-inflammatory component is a tiny fraction with huge side effects. So let's look at the evidence that supports the damage and what you can tell from looking at your cardiovascular risk. So particles, LDL particle sizes and numbers and all, good call, type A pattern, doesn't matter. I can tell you that information just from 4, maybe 5 numbers. The 5 numbers we're going to look at is total cholesterol, HDL, triglycerides, LDL, and ideally, and LabCorp will give this to you, VLDL. Those are the 5 things we're going to look at. And some of those are calculated. So let's go down the pathway. So what is the issue? The issue is sugar. The issue is carbohydrates. The issue is hyperglycemia, chronically elevated blood sugar that triggers endothelial inflammation, narrows the blood vessel because of swelling of the blood vessels, hypertension, together with that, even transient hypertension. And that triggers the clotting cascade. And the final marker of that clotting cascade is lipids. We've gone through that in the last 2 videos. So let's look at how, because all of these markers are produced directly or indirectly in the liver. The liver is the holy grail. The liver is the center of your metabolism and controls lipid metabolism, not the fat cells. I will argue with Ben Beckman every single day about that fact. The liver controls everything, not the fat cells. Okay. Ben, I'd love to go toe-to-toe with you on that. And Ben's just a great guy. He works with cells, I work with bodies, we meet in the middle. So how does the liver work? Okay. When you eat food, the liver goes into hormonal storage mode. And there's a subset of hormones that are related to the storage of food, irrespective of whether you've eaten a big ribeye steak or you've eaten a tub of ice cream. The liver goes into storage mode. And all of those factors, except one, travels up the portal venous system directly to the liver. It's called the first pass effect. So everything from the gut travels to the liver, except for one thing. And the exception is long-chain fatty acids. Long-chain fatty acids. Whether they are monounsaturated, polyunsaturated, or saturated fats, those get absorbed into the lymphatic ducts and go directly up the lymphatic chain to your left neck, into the blood vessel system, into the systemic system, to your fat cells, and they get stored in the fat cells. They get transported by a molecule called chylomicrons. Big transport ships. And the chylomicrons are made from bile, and where does bile come from? The liver. Bile comes from the liver. So bile goes into the gut assembles the fat in these molecules called chylomicrons, goes up the lymphatic system to the fat cells. Okay, so that's what happens to fat. All the other elements, medium and short chain triglycerides, fat, a lot of your vitamins, even the fat soluble vitamins, some of them absorbed in the lymphatics, some of them absorbed directly to the liver. But for all argument's sake, for the arguments of this discussion, everything else goes up the portal vein to the liver, and the liver, everything flows through the liver. It's called a portal venous system. The liver extracts, and there's a very high first pass effect where everything gets extracted, gets put into the hepatocytes on the front end, and on the back end they get modified and they get released into the systemic circulation as it leaves the liver. So this liver is this huge factory with very high capacity for absorption and release. And what happens in the liver? Under the influence of insulin, which gets triggered by what you're eating, amino acids get made into protein. It's an insulin effect. We're going to ignore that for now. Okay? But the glucose, the sugar that we eat, and the medium chain triglycerides get absorbed into the hepatocytes, and primarily the sugar, glucose, fructose, galactose, but primarily glucose, gets converted in the liver cells to triglycerides. It's called lipogenesis. Okay? And the liver cells have a huge capacity to turn excess sugar into fat. That's how it protects your body at first from hyperglycemia, from elevated blood sugar levels. So the liver rapidly generates fat, and we've done experiments. I've done experiments in my Ph.D. Within 3 hours, I could create a fatty liver by infusing sugar into the liver. So the liver makes those triglycerides, and you get these vacuoles, these little foam cells or lipid layers, lipid bubbles, little balls of fat in the hepatocytes that you can see under the microscope. And in fact, if the concentration is very high, it can actually eventually kill the hepatocytes. But most part it doesn't, and that leads to fibrosis, and that's why fatty liver disease is the commonest cause of liver disease in humans right now, superseding alcohol. Then under the influence of insulin, the liver produces a molecule called VLDL, very low density lipoprotein. Lipoprotein, fat and protein, which on the outer surface has a water-soluble molecule. On the inside, it is fat-soluble. And in the fat, in the liver cell, triglycerides, phospholipids, and cholesterol also produced. Cholesterol being produced under the influence of insulin by the liver, gets packaged into these cells, these VLDL molecules, and they get released from the liver into the bloodstream, into the systemic bloodstream. Now, that's a rate-limiting step. So the rate-limiting step in the liver is the production and release of VLDL. But you see your VLDL numbers going up. My normal VLDL in an insulin-sensitive person is 10 or lower. So the ideal number is a VLDL number of 10 or lower, which tells me that you're not turning excess sugar into fat. Okay? Important. That's the marker I use for insulin sensitivity. So VLDL then travels to your fat cells and docks with the fat cells and dumps those triglycerides, those phospholipids, that cholesterol into the fat cells. A little bit gets transported to the cells, but remember, during storage mode, during eating, all the cells are tasked with the uptake of a variety of nutrients that we've eaten. They don't want that extra fat, but the fat cells are designed to store that. So their fat cells go into storage mode, and on the back end, VLDL gets processed, it gets emptied, and VLDL shrivels down and becomes IDL, changes its name to IDL, and IDL rapidly changes its name to LDL. So if the traffic is high VLDL, high, big, fluffy, big, fat VLDL that's transporting all these triglycerides made from sugar to the fat cells, that big, fluffy VLDL is directly related to a small, dense LDL. Okay? So high VLDL, small dense LDL is a direct measure of hyperglycemia. It's a marker of hyperglycemia, of elevated blood sugar, because that comes from the conversion of excess sugar to fat. Once you reach a VLDL level of 10, you know that that is no longer happening at a significant amount. Happening just a little bit, but not at a major amount. And that is insulin sensitive, that number 10. But if the VLDL level is high, you can be assured that your LDL is small, dense molecules. It's that simple, folks. You don't need NMR, you don't need anything else to be able to tell you that. So VLDL goes to those fat cells, deposits the fat, and you gain weight. But it's a direct marker of elevated blood sugar, because some does spill over into the systemic system. Now, when you eat a large load, the liver goes into triglyceride making protocol under the influence of insulin. And remember, the liver is immune to a certain extent to hyperinsulinemia, to insulin resistance, because it doesn't need insulin to take up sugar. It's one of the few cells that has a receptor that does not require insulin. Okay, so it's an insulin-free receptor. So it's a GLUT receptor, GLUT receptor, which are the insulin-based receptors. Doesn't need them. So glucose goes into the cell, becomes triglyceride. So if your triglyceride level is high, that is a direct marker, not a cause, but a direct marker, together with an elevated VLDL, of hyperglycemia, and we know hyperglycemia causes vascular damage. So high triglycerides, high VLDL, always associated with each other, always a marker of vascular damage, of cardiovascular atherosclerotic damage. And if your triglycerides are above 150, my normal triglycerides, if you are insulin sensitive, that triglyceride number should be 75 or lower. And if it's significantly above that, certainly if it's above 150, you have a direct concern about cardiovascular risk. But the triglycerides didn't cause it. They're a marker of hyperglycemia because your liver is struggling to cope to make adequate triglycerides. So elevated VLDL, elevated triglycerides. And then the final marker to tell me about your cardiovascular status is that during storage mode, your liver is making triglycerides, making VLDL. And the storage mode hormones, insulin, testosterone, T3, human growth hormone, somatomedins. Okay? Those are the 5, it's actually insulin-like, now they've changed, somatomedins have changed their name to insulin-like growth factor type 1. Be that as it may, those are all associated with storage mode. And if you're snacking, if you're binge eating, if you're overeating, you remain in storage mode for a long period of time. Because remember, if you have a big meal, it takes your gut and your liver a very long time to metabolize that. 3, 4, 5, 6 hours. So even if you're doing intermittent fasting, but certainly if you're not fasting, if you're snacking where you're putting stuff in your face on a regular basis, even small amounts regularly, you remain in storage mode, you remain in insulin mode. And remember, the human body ideally cycles through storage mode and then through prolonged utilization mode, where you take food in, you store it, you distribute it, and then you've got all this food coming back at you from your stores, and you go into utilization mode under the influence of glucagon, where glucagon is releasing sugar into the bloodstream because it's low, and turning sugar and fat, glycerol from fat, and protein into fatty acids and into ketones using gluconeogenesis, primarily ketones, and fat being released by your fat cells. So in utilization mode, you're getting fat from your fat cells, cholesterol, phospholipids, it's building mode, being transported out of your fat cells to your cells in LDL. So therefore, the LDL is big, fluffy, triglyceride-laden LDL, the A pattern, not the small dense, but the big fluffy. Okay? Liver in utilization mode is not making fat, it's breaking fat down. It's in ketogenesis under glucagon, so VLDL levels are low, and you're not producing triglycerides, so triglycerides are low. Okay? So big fluffy LDL has to be present. The A pattern, irrespective of particle number. Big fluffy LDL has to be present. when your VLDL levels are low and your triglycerides are low. There's no magic to this, folks. And under those conditions, that means the glucagon is active, insulin levels are low, you're producing ketones, you're probably in ketosis. And the final marker, folks, high-density lipoprotein, HDL, gets produced by the liver during utilization mode under the influence of glucagon. So if your insulin levels are low, if you're in utilization mode, you've got to have big fluffy LDL, and you have HDL molecules, small HDL molecules that are going out and scavenging and coming back to the liver. So your HDL molecule is a direct measure of insulin sensitivity, and you want your HDL high. I typically look in my practice for insulin sensitivity as an HDL number above 75. But as you go for a prolonged period of time in utilization mode, and there are three factors that govern utilization mode, your HDL goes up. And HDL goes up very, very slowly. Why? Because typically, even when we're eating non-carbohydrates, the keto community makes this mistake. Binge eating. Oh, I can eat as much as I want to. I can eat like Sean Baker and eat 24 pounds of ribeye steak every day. No, you can't. You are not Sean Baker. Unless you are. Hey, Sean. but the point is that we overeat. Oh, it's keto, it's carnivore. And then we stay in storage mode for a long time, and our triglycerides may be low, but our HDL is also low. Not a good place to be. We want to eat less. We want to be in utilization mode for a long period of time. If you're snacking all the time, if you're not going for long periods of time, you can call that fasting. Snacking all the time, HDL is low. Even if you're snacking on pepperoni and cheese, your triglycerides may be low, but your HDL is also going to be low. It's not going to be up. So binge eating disorder, snacking, and carbohydrates cause low HDL. And a low HDL is associated with cardiovascular risk. So it's very simple, folks. You can just look at your 5 numbers, and I kind of ignore cholesterol. You want your cholesterol to be above 200. The higher it goes, doesn't matter. You want your LDL. My normal range for LDL is 120 to 300 as a number, as a calculated number. But in the face of low triglycerides and high HDL and low VLDL. And if that's the case, if that's your profile, you don't need an NMR. Now, here's the tidbit that I've left to the end. And I know a lot of you dropped off because you're bored or whatever it is. ADHD has kicked in because you've eaten too much sugar. Here's the tidbit. The one number, the one place, and we looked at something called the PROSPRE, P-R-O-S-P-E-R. You'll see the slide, you'll see it in the show notes. The PROSPRE trial, which was a statin trial. And there have been a couple of trials that have showed exactly this. The one place where categorically and absolutely, not by relative risk, but absolutely, statins do show a benefit. They do show a benefit. Is when your HDL is very low and your triglycerides are very high, which we know is associated with hyperglycemic injury to your cardiovascular blood system. So we know that those are markers of profound insulin resistance. But there is a direct benefit to treating people with low HDL and high triglycerides on a statin, and it does statistically reduce cardiovascular risk. Look at the slide. And I've been remiss, so this is an apology from me. I've been remiss in not discussing that with many of my patients. So it's very important to understand that the benefit for a statin, as far as we've seen exclusively, yes, there's some small immune benefits, anti-inflammatory benefits, but the primary benefit, the absolute benefit in terms of cardiovascular risk is when you have a low HDL and high triglycerides, and that is data from the PROSPRE trial that I absolutely believe, so does David Diamond, and this information does come from David. So when we have high triglycerides and low HDL, which is exactly that scenario, what should you do? What should you do? And here's my advice. Number one, the single most impactful thing you can do is go on an ultra low carbohydrate diet to reverse those ratios. but they may take some time to reverse, to lower your triglycerides, to elevate your HDL, independent of LDL. Single best thing you can do, low carbohydrate diet, as a sustainable way of life, not just as a diet for a little while. Second thing you can do is use a GLP-1 agonist, an Ozempic, a Trulicity, a Mounjaro, a Wegovy, a Rybelsus, a Mounjaro, it doesn't matter what the GLP-1 agonist is, to revert, to accelerate the correction of insulin sensitivity together with your low carbohydrate diet. Don't use the GLP-1 without that. Low carbohydrate diet plus a GLP-1, and now we have two choices, one of two or both choices in terms of reducing cardiovascular risk. You could take a statin. You can take a statin, but it's got a high side effect protocol. This is a place where you say to me, I've got a low HDL, I've got a high triglyceride. Should I be taking a statin? Yes. It's not you should be taking a statin, you should be doing something to reduce your cardiovascular risk, and statins do help. The other thing that helps is a baby aspirin. And either of those two, possibly even both, is the right way to go. However, once your HDL starts to come up, in fact, once your triglycerides start to come down and your HDL starts to go up slightly, you don't need that therapy. You certainly don't need the statin therapy. So my algorithm is a low carbohydrate diet, a GLP-1 agonist, and then an aspirin plus or minus a statin, depending on indication. And that is a best practice. So I'm going to change how I recommend patients coming off statins or going on a statin based upon HDL triglyceride ratio. And if you understand that, but you understand why the risk is there, and you do something about it, you can reduce your cardiovascular risk to zero. Not your CAC score, but your ongoing risk to close to zero by doing this. That's a brain breaker, isn't it? This is Dr. Rob Cybus. I am the Carb Addiction Doc. If you want advice for you where you currently are, and you want your blood work done, you want your blood work analyzed, give me a shout. Text us, WhatsApp us, email us, leave a voicemail, 561-517-0642. Anywhere in the world. We will get your blood work done. We will help you with the therapies. Take care of yourself. Until next time.